essentially we found a specific pathology because of a large ovarian cyst which was responsible. And what we'll do in this perspective is try to discuss about various scenarios in which different forms of this peripheral precocious puberty presents. How is it different? What sort of evaluation is required, and how do we manage about this? This was a 3-year-old girl who presented with vaginal bleeding. She had thelarchy within 2 weeks, stage 2 breast development and pubic hair, and she was not very tall in that regard. So this is a very, very unusual scenario. Normally we talk about how there is a gap of approximately 1 year between the onset of thelarchy to the progression as far as the vaginal bleeding is concerned. Now, in this scenario, what we are seeing is that there is just some breast development which has happened in the last 2 weeks. And since then, you have a vaginal bleeding, which suggests that this is an extremely hyperestrogenic state. So estrogen becomes too high, the breasts don't get time to progress, and you have got vaginal bleeding. Now, vaginal bleeding typically happens when there is a withdrawal. So usually it means that the cyst now is not forming a very high level of estrogen. So your estrogen levels are coming down, and now the bleeding happens. So this is what was assumed in this case. There were no features of cafe au lait spots or rickets, and the parameters which showed that the LH and FSH was undetectable, and estrogen levels were reasonably high at that point of time. Now, what I'm trying to say is that this is the phase when your estrogen is weaning off. So probably this is the time when this 43 estrogen, which is very high for this girl, the levels would have been even higher, going up above 100 also in many scenarios of peripheral precocious puberty. So this was a classical case, and it was found to have an ovarian cyst which was detected. Now, the big question here is what to do from here. So most of us thought that, okay, there is no other clinical features of hypothyroidism, no features of McCune-Albright syndrome. So let's reassure this girl and just follow up on that perspective. But what happened that she presented a couple of years later with a trivial fall resulting in fracture, which was attributed to a fibrous dysplasia, which was developed. Now, there are no other clinical manifestations of McCune-Albright at that point of time, yet she actually behaved like McCune-Albright in that perspective. So this really highlights that even if you have an isolated ovarian cyst, if it's happening at a very early age, you have to think of a genetic cause. And I always say if you have a severe, syndromic, soon, or segregating etiology, these are the 4 conditions where genetic causes have to be considered. And McCune-Albright is essentially a somatic disorder. And when you talk about a somatic disorder, the manifestations will depend upon how many cells are affected. So you may or may not have the entire spectrum, which is there in that perspective. So what we'll try to do over the next hour or so is try to cover 4 of very interesting cases and how they differ and make appear similar also in various perspectives to go from there. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources regarding pediatric endocrinology, including courses, online courses for fellowship and diploma programs. We do run a number of monthly programs like our lecture series for postgraduates, for grand rounds, and these programs try to cover the entirety of pediatric endocrinology over a 2 to 3 year period from that regards. Our mobile application helps guide, evaluate, assess, and manage conditions along with our publications, both basic and advanced pediatric endocrinology. And just recently, last month, we brought out this pediatric endocrinology protocols, which covers the various aspects of evaluation and management. Now, what we're going to do over the next hour or so is try to cover 4 cases. So we have got an infant with ovarian cyst, which initially Dhwani will talk about. Then we have cyst with cystic lesions, skin lesions, young girl with ovarian cyst, and finally a girl with short stature and ovarian cyst. Before we do that, we will have a look with regards to a basic understanding of what we are talking about before we go ahead deep in terms of individual cases. So when we talk about puberty, we know that there are 3 major organs which regulate the pubertal onset: the hypothalamus, which produces the GnRH, the pituitary, which produces the gonadotrophins, and the ovary, which produces the estradiol. Now, within that, we typically classify this into a central form of precocious puberty, where you have got a high level of gonadotrophins. It's more of a concordant development. Typical gap between thelarchy and vaginal bleeding is around 1.5 to 2 years. If it's less than 1 year, we start thinking that it doesn't look like a central precocity, and then mostly it's idiopathic. While peripheral precocious puberty is more like a ovarian estrogen production, characterized by hypogonadotropic scenario, low LH-FSH, discordant pattern. Like in the first case, you had got a breast development and suddenly you have got the vaginal bleeding. So if you have a history that, okay, last 1 year, there was breast development and now bleeding happens, this looks more like a central precocious puberty. If you have no breast development and you have a bleeding, this looks like a local cause. But if you have some breast development and yet you have got bleeding, this discordant pattern suggests a peripheral precocious puberty, which is usually more likely to be pathological. Now, there are various causes which can cause the central precocious puberty, which will include effects like tumor, radiation, trauma, any insult will cause that. But most of it is 95% will be idiopathic. So beyond 6 years, we do not want to do unnecessary evaluation in the form of an MRI to identify a lesion. There are rare genetic causes which may also be there in that regards. Now, what our focus is most towards this aspect of the algorithm. So we'll talk about largely about McCune-Albright syndrome as a possibility. Hypothyroidism, we all know. The TSH, when the levels are very high, is going to act on the FSH receptor to cause this development. Rarely you can have an estrogenic adrenal tumor, which can cause that. So within the scheme of causes of precocious puberty, we will be focusing about the peripheral precocious puberty, which will include ovarian, and we'll focus pretty much all these three as a group. And then you can have rare scenarios like aromatase, excess, or exogenous or Peutz-Jeghers syndrome as a form. So functional ovarian cyst is a very common finding, which is basically means that your dominant follicle has become bigger and it's producing estrogen, and it's usually LH independent. Now, the course is usually fluctuating and often it's a one-off phenomena. I'll talk about that as to if you have a single isolated cyst, whether you need to worry about genetic causes or not. That's an important issue. But mostly it's a single event. It will not happen repeatedly if it's just a functional cyst. And you will have a high estradiol levels, which will be there in that regard. So management largely is observation, and we'll talk about criteria when you need to worry about and when you can think of torsion or malignancy as a possibility. So a cyst which is less than 10 centimeters typically, who doesn't have a solid cystic area, does not require a surgical intervention. You can manage it conservatively. Granulosa cell tumor is exceedingly rare, but it is known to occur in children. So it's basically will have a very rapid production. Your estradiol levels will be sky high. So if you talk about a cyst, so what happened? There was a cyst, there's some bleeding, some breast development, and then regresses. Here it will be a continued process. It will continue to grow from that perspective. Your estradiol levels will be very, very high, and you will have other markers which will be produced. So if you have a granulosa cell, it's going to produce more of inhibin, AMH, all other factors will come from there. And you may also have tumor markers which are being produced. So this is more like a ovarian estrogenic tumor. Very rare, but if you have very rapid estrogenization, which is persisting, and you have a large cyst which has a solid cystic area, start worrying about this condition. Really, management, of course, is cumbersome. You will require gynecological referral, surgical intervention, and further management will come from there. Now, one important condition which we'll be discussing today is the McCune-Albright syndrome, which is basically a problem in the GNAS1 region. So the GNAS is an important part as far as the cyclic AMP pathway. As far as the reproductive phenotype is concerned, this is because of overexpression or overfunction of the LH and FSH receptor, which basically will act on the ovaries to produce breast development, which will happen early, and you will have this discordant menarchal level. Again, the estrogen levels will become very, very high. Importantly, because you do not have much effect as far as the adrenal axis, you will not have pubarchy. They will present purely with a vaginal bleeding and some breast development. Because of very high FSH receptor expression, you will have large ovarian cyst. And the typical pattern is that, okay, you have got development now, you have got bleeding, you see a ovarian cyst, then the ovarian cyst regresses. There is a period in which there is no significant development, and then the second cyst appears. So it's like in the somatic areas where you have a problem in the ovaries. Now, this is a somatic defect. So not the entire ovary is affected. So it's not behaving like a testotoxicosis. Now, if you talk about testotoxicosis, that is a LHCG receptor activating mutation. So the entire testis is producing a huge amount of testosterone. This is not working like a ovotoxicosis. This is like certain cells in the ovaries, certain of these oocytes or the follicular cells will be starting to become more active. And so time and again, some of them will be selected and they will start producing. So it's a off and on waxing and waning phenomena, which is common in the setting of McCune-Albright syndrome. Now, TSH, of course, there are many other hormones which act through the GNAS pathway. So in TSH, it will cause thyrotoxicosis. You will have growth hormone excess causing acromegaly in certain scenarios. You may have a ACTH independent Cushing syndrome scenario. Skin lesions, of course, which are very, very important, are again because of the melanocyte stimulating hormones. So MSH hyperactivity in certain regions will cause pigmentation, and you will have bone abnormalities in the form of hypophosphatemic rickets like scenario, or you may also have a scenario of fibrous dysplasia. So the classic description of McCune-Albright syndrome, which is imprinted in most of our minds, is a combination of peripheral precocious puberty along with café spots and fibrous dysplasia. Now, what you need to remember is that this is a textbook description, and in real life, the patient has not read the textbook. So they will not come to you with these three complaints that I have got McCune-Albright because I have got an ovarian cyst, I have got a café spot, and I've got fibrous dysplasia. They can come with multiple varying manifestations. They may just come to you with isolated fibrous dysplasia, which is a very, very common, most common presentation, I will say. So you will have bony lesions, some bony swelling, especially in the skull areas, in the hand. There may be a trivial fracture. So you have to keep your eyes and ears open that, okay, this could be a fibrous dysplasia. Think of McCune-Albright in that regards. They may present to you just with recurrent ovarian cyst, where there is no other manifestations which are present that you have to be worried about. Similarly, in scenarios like macronodular adrenal ACTH independent macronodular disease, you have to think of a possibility of McCune-Albright. Any child who has got growth hormone excess, McCune-Albright is a strong possibility. Any child with hypophosphatemic rickets, think of McCune-Albright. So you don't need to have the entire combination. Even a single manifestation becomes important. I'll talk a bit about criteria about McCune-Albright a bit later, subsequently. So this is a somatic defect, variable and fluctuating course, and you may also have a secondary central precocity. Now remember, it's a defect which is there in the GNAS pathway. So what's basically happening is that your pathway continues to be active because the GTPase action is compromised. So the whole process of cyclic AMP is continuously being produced in that regards. Now this defect may not be present in the whole blood because it's a somatic one. So often most of the tests are not able to detect this, and this becomes important from that regards. What about hypothyroidism? So uncontrolled hypothyroidism will cause a very high level of TSH, which will act on the FSH receptor to cause large ovarian cyst, because there is a structural homology between the TSH, FSH, LH, HCG, and we have discussed this in many details. And this will cause large ovarian cyst. They may go up to 8 centimeters, 10 centimeters. I've seen cases who have been referred for surgical management, but then they are found to have hypothyroidism in that regards. They will have breast development. They will, of course, have vaginal bleeding, but they will have a delayed bone age because of the hypothyroidism primarily, and very importantly, because of hyperprolactinemia, they will have a low level of LH. So high apparent FSH activity, which is going to cause more ovarian stimulation, and low level of LH will basically mean that you have got no amount of pubarchy. So again, if you compare this scenario to a boy who presents to you with a severe uncontrolled hypothyroidism, they will again have the same scenario: large testis and no pubic hair. Similarly, large ovaries and no pubic hair. So effectively, von Wieck-Grumbach syndrome, as the term is called, is similar in manifestation in both boys and girls. It's just a matter of how they present. Depending upon menarche, you will get it much more easier in girls. In boys, as I said, FSH is a minor player. So high FSH will do nothing. It is not going to cause any change. It will only cause increased Sertoli cells, causing more testicular size from that regards. Again, no pubarchy is there. Rare scenario, which is similar to manifestations as far as McCune bed is concerned, is Peutz-Jeghers syndrome. It's a problem. It's considered to be a neoplastic disorder, part of endocrine neoplasia syndrome. So it's the STK11. Again, this is going to cause more cellular growth. So all of these are causing more cellular growth. Manifestations are ovarian sex steroid tumors, which may again cause precocious puberty, which will be peripheral in the form. And very importantly, you will have pigmented lesions, which are there in the mouth, like lentigens. I'll showcase one of my papers, which I've done in Australia, which showed that MAS may also have these form of lentigens, and they may also cause gastric polyps. So there is an overlap between STK11 and GNAS1. So these are like all the growth pathways which are going to be stimulated. Subsequently, we'll discuss about that. Aromatase excess, extremely rare scenario. Again, it will cause precocious puberty. You will have high levels of estrogen and you will have increased growth and bone age in that regards. Now, when should you think of a peripheral precocious puberty? So basically, if you have a very simple traffic as it's going like this, it's a concordant pattern, it's more likely to be a central precocious puberty. But if you're traveling somewhere in Kanpur or something where you find such a bizarre sort of a traffic and everybody is going here and there, you think of it's more like a peripheral. It's like a organized chaos. That's what peripheral precocious puberty is. So it's a fast and discordant pattern of peripheral precocious puberty. Of course, the most important tests are gonadotrophins, and we all talk about the importance of LH, which is much more important compared to FSH. Invariably, if you think of central precocious puberty, your LH FSH will be 0. Anybody who has a high FT4 should have a 0 TSH. Anybody whose cortisol is high should have a ACTH, which is undetectable. Similarly, if you have very high estrogen, you expect your basal LH to be less than 0.1. So generally, you are not in much doubt, but you can do a GnRH stimulation test if there is a confusion. You give a triptorelin or you give leuprolide 20 microgram per kg, 100 micrograms, and then you check your LH levels after 0, 2, and 4 hours, and you will find that there is lack of response, which will suggest that this is a peripheral precocious puberty. For me, a very high estrogen level and an undetectable LH is pretty good enough. You then have to go for imaging in that regard. So what you do is that if you have complete development and your LH is prepubertal, you have to go for peripheral precocity and go for imaging.
So we have this 6-year, 5-month girl who was born of non-consanguineous marriage, and her mother bring her because of the concern of early puberty. According to her mother, she noticed the development of breast. So day, 1 week ago, but there was no pubic hair or axillary growth, according to her. And she started to bleed within the 3 days of breast development, but it was non-cyclical. It was just one episode. After the bleed, she observed that there was a reduction in the size of the breast. And she also told us that there was no sudden increment on the height and there was no any virilization. She told us that there was no history of any accidental intake of any medicine. There was no history of any abdominal distension or pain. And she never had any constipation or cold intolerance or dry skin. She don't have any bony deformities or hyperpigmented patches.
So this is so how is this case different from the 2 cases that we
Two cases, Dhwani's case presented at the age of like 2 years, 3 years, and Dr. Priyanka's presented at very early, like 1 year of age, and she presented at later in the early childhood at 6 years of age. So there is a later presentation of this.
So this is very, very important that you have a much later presentation. The chances of any congenital disorder becomes less likely because it's unusual. It won't happen with McCune bed not present at
6 years of age.
That's very important.
Right.
Now you gave a very important history that the breast size decreases
after.
What does it mean?
It means that something has happened. The estrogen has increased, and once the bleeding has occurred, the estrogen level has decreased, and that has led to the decrease in the estrogen level, and that is
your estrogen levels decrease,
Yes.
so the breast decrease.
Decrease.
And at that time, then you have the bleeding. Because of the
Withdrawal.
withdrawal.
Right,
This
right.
is what has happened. So probably now when the child has come to you, the cyst is not producing that much
Any
estrogen.
estrogen, right?
So which condition does this rule out?
This has ruled out like any cyclical cause, any persistent or
It has ruled out a tumor. If it was an autonomous tumor, you won't have this sort of phenomenon. The estrogen will continue to grow. Now, when you have an ovarian cyst, basically, what is an ovarian cyst? Structurally, what do you mean by an
ovarian cyst is is a follicle. It is a filled with a fluid, clear fluid.
You have got a big
follicle filled with
just
fluid.
surrounded by a granulosa cell and theca cell. Now, as the cyst becomes bigger, there will be a time when you won't be getting enough supply of nutrients, vascular, and whatever, your hormonal and whatever. And then once it outgrows its size, it's going to shrink off and the hormone level will fall down. But if it's an autonomic tumor, like a granulosa cell,
yes.
So this fact of this coming down is a positive sign in that regard.
Yes.
Okay, carry on.
As there was no history of any previous treatment, there was no history of, she was AGA, and on examination, her vitals were completely normal. And her journal examination, there was no coarse facies, no goiter, and no bony deformities or cafeoli spots, and no abdominal distension or any tenderness. On the anthropometry, she was short. Her height SDS was minus 2.9 SDS, below minus 2.9 SDS, and even the weight was compromised. It was less than minus 3.3 standard SDS. It was clearly showing that she has a growth failure of a nutritional pattern. And her SMR staging was B2, pubic hair stage 1, and she had a bleeding. So definitely,
again, as compared to Bani's case, this is again B2.
B2, yes, sir.
But Dr. Priyanka's case had a more
B3,
longer exposure, that's why it became B3. And that was the only girl who had growth acceleration.
Yes, sir.
Because there was recurrent episodes of estrogen excess. In this case, in fact, she is short. So you should think of hypothyroidism.
Yes, sir.
And in your case, the height was normal.
15.
So it was normal. So again, which means it was a recent estrogen exposure.
Yes. So if I put my differentials on, so with a short stature and the early puberty, so the first differential will be the hypothyroidism first. But if I keep the early puberty, so exogenous intake of the estrogen, if the girl has accidentally intake the mother's estrogen pill, that it could be one of the possibility. Functional ovarian cyst, it could be the most likely possibility. And McCune-Albright syndrome, as it is not possible. It is the rare possibility to onset at this later presentation. So it is the rare possibility. Too late, and as she has a one onset of the bleed, so tumors is less likely to happen because she has just one onset of bleed. So, and if on the investigation, what we found that the this thyroid profile was absolutely normal. Both the LH and FSH was prepubertal, and the estrogen was 42, which was high for this age. So clearly, showing that this is going in the favor of this peripheral precocious puberty. And when we did the bone age, it was 5.5 age, which is delayed. Not delayed, just appropriate for the age. And when we did the pelvic ultrasound, what we found, the endometrium thickness was 2.9 mm. And we found a single cyst in the right ovary, which was 2 centimeter into 3 centimeter. And both the ovaries were absolutely normal in shape and in echogenicity and with no adnexal mass. So if I summarize my case, we had a female with the rapid breast development and subsequent vaginal bleeding with no pubic and axillary hair growth at the age of 6.5 years. And the bleeding leads to a reduction of breast size, and it was not associated with any cyclical episodes. There was no evidence of exogenous exposure and acute abdominal pain, distension, or bony deformities. And in the light of low gonadotropins and high estrogen normal thyroid profile, the most likely diagnosis in this case would be the functional ovarian cyst. So management, we manage this child conservatively, and on the follow-up, she visited a few days back. She had attained the normal pubertal development and Minaki at the 11 years of age.
So there was no repeat bleeding?
No repeat, yeah.
So this is the most common manifestation of isolated functional cyst. About how do you manage the ovarian cyst?
So should I proceed?
Okay.
So if we go by the definition, as Dhwani has already gone through this, what the this ovarian cyst is. So generally the physiological ovarian cyst is common in childhood and it does not exceed more than 10 mm. But by the definition, ovarian cyst is a fluid-filled image and it is generally more than 20 mm. And it is purely anechoogenic and it is filled with clear fluid, has a regular wall, and it goes in the favor of functional ovarian cyst. And it has already been discussed. It has an incidence of less than 5% in the age of birth to 8 years. And the functional ovarian cyst includes the follicular ovarian cyst, and it could also be the corpus luteum. And the causes of the central precocious puberty, McCune-Albright syndrome, overt hypothyroidism, aromatase axis, and non-classical CH can also cause, but
even
POR can also cause.
That's why if you look at that, they had done POR in those studies.
Yes, sir. And Proteus syndrome can also cause this functional ovarian cyst. And presentation, abdominal pain, rapid breast development, vaginal bleeding, and specifically cephalospots and fibral dysplasia could be the presentation. And the lab investigation, as we know, the thyroid profile, gonadotropin, estradiol levels, skeletal survey, and the bone age should be done. And the uterus and the ultrasound of the uterus is the most important and the best investigation to look for the ovarian cyst. And if we found any echogenicity and irregular walls in the cyst, we should go for the tumor markers like AFP, beta ACG, and the CA99, which are the. And the studies had shown that they had done 1818 ultrasound studies of the prepubertal girls, and they found that only 99 patients presented with ovarian cyst, and only 82 of these patients have cyst that was less than 10 mm, and only 17 had cysts that were greater than 20 mm. And only 5 of these 17 patients presented with pubertal development. So by this data, non-functional.
And you may not even pick up. That's what I'm saying. So you don't get too worried if you see ovarian cyst.
So if we go by the management, generally the cyst is anechoogenic in the ultrasound. We can manage it conservatively and we observe it. Generally, the size of the cyst decreases in 2 to 3 weeks. We monitor it monthly by the USG until it resolves completely. And the surgery is indicated when the symptoms, when there is significant symptoms, when there is a concern for malignancy, if there is a solid, like if there is a echogenicity in the cysts, if there is a multilocular margins, if there is increased blood flow in the Doppler, if there is increased AFP, there is a torsion, or if there is a failure of the cyst to resolve on the serial ultrasound. So these are the
issues. More than 10 centimeters, you have to be really bothered about it. If it's between 5 to 10 centimeters, generally follow up. And if it's not resolving by 6 months, you then refer on that. So less than 5 centimeters, nothing to worry. 5 to 10 follow up and not decreasing, sent to a gynecologist. More than 10, immediate referral. Of course, if you have solid cystic area, you have to worry about right away.
10 centimeter is valid for each and every age group?
More or less, because they will be much bigger.